I was invited here as a motivational speaker. I guess it gives me some sort of a poetic and a mimetic license to talk about HeRC and how can we put it in an international context. And one of my professors had told me that if a German had found a stick in the road, he said, oh, well, what's wrong with it? He would ask. But when a British man found a stick, he was asking, what can I do with it? So with this pragmatism in the World Health Organization for the last 15 years, I'm trying to do what you can hardly see, classifications, terminologies, and standards. I have known about HeRC before its conception with Ian's work, and really trying to do some of the HeRC beyond the Britain's shores. I mean, in Barcelona, in Singapore, in Sydney, can there be other HeRCs nationally, internationally, and can we benefit from it? And what would be the interactive effects between the Center of Excellence here in Northern England and the others? And there will be, of course, extension of data, but you will also benefit from world expertise and know-how. And you can also export your know-how to them as well. So that is the gist of my talk in a nutshell. And I am pretty much in tune with what Ian called social machine of health e-research. I think linking humans is more challenging than linking data, he said. And what you are experiencing in UK is just the beginning. And in a global scale, it is even worse. So let me start with world's most quoted myth with my license, that it is part of our world's heritage culture, the Tower of Babel. You know this picture, I suppose. The slides projection is not that good, but anyways. I think, again, Ian had started viewing big data as a solution is a myth, he had said. So if we were to dispel myths, for those of you who don't know the story, although it's in the Old Testament and the Bible and so forth, the king wants to reach the heaven, and he wants to build a big tower. And when God notices that, this is just the beginning, she says. Let's go down and confuse their language. So she gives 70 languages to the workers, and then the build-up of the tower is arrested. So I have read the Herodot's history. After 460 before Christ, he goes to Anatolia, where I come from, and identifies a remnant of a tower, say that it is impressive, but it is just useless. So I think in the morning there was a discussion about avoiding the negative consequences. I think what you're doing here in HeRC is exemplary. I came to believe that as an attempt. It is one of the best attempts under the sun. And how can we avoid an e-Tower of Babel from this, especially if you want to do it internationally? So this is the view that I have been sharing since 2003. There is a man in a white shirt in front of a whiteboard. You can call him Ian Buchan. And he's thinking of how can we optimize our health services, looking into this. And then, we try to identify all the clinical paths or, in an analog way. But we really have to create something digital, an e-version of it, and put it into a very complex scene of health informatics. So that is how we are planning to switch from analog to digital. And our vision is that we have a Lego set, not to rebuild the Tower of Babel from Lego sets, but ICD and another classification of consequences of disease, ICF, and health interventions. And we are using them at different use cases for population health, like London Bills of Mortality. We are reporting that for clinical integration of care, outcomes, safety, administration. Basically, it is used in North America for billing and for reporting. All WHO, OECD, or whatever report is using those codes. So that is what we are doing. And by the time we had come to revise it for ICD-11, there had come the emergence of electronic health records. So how do we make use of the electronic health records and There, we said, okay, in order to make sense of the electronic health records, the terminologies have to be bound to the classifications, okay? And for this, we needed to some sort of, not to reinvent the wheel, but we really had to have the story of the wheel be built into that thinking, and possibly plan for the future wheels or vehicles without wheels. And doing this, when you look into the digital models, I mean, the world has been inundated with tsunamis of e-bays, e-trades, e-banking, e-media, e-tickets, and so forth. And next to a theater, you have already seen the movie about e-health. Okay? And it is coming as a new business model or existing business model. And how it is going to shape is not how health professionals going to think about it, but also how the external partners, computer industry, economics, it is 15% of the global economy, to say the least, minimally. So they won't let it to medical informatists at all. So how do we do that? And thinking that all the problems will be solved by computers, I used to quote a non-computer person, Picasso. When asked, Picasso said, computers are stupid. They cannot ask questions. They can only, if you enable them, program them well, can give you answers. So in our system, how can we make computers understand our health information was the chief question. And allow me to speak about ontology. And in that slide, you can see a New Yorker cartoon. I took liberty of putting the guru of ontology, who is in the audience, Alan Rector, in there, who's teaching us how, when you say ice cream, you know, apart from the digital language processing, natural language processing, I don't say ice cream, but ice cream. And so there are different forms and shapes of ice cream, and it is not what Jean-Paul Sartre said in Nothing and Everything type of thing. It's not the organization of reality, ontology, maybe in a narrower sense. Therefore, I dare to call it nontology. Ontology as a computer science is an explicit operational description of the conceptualization of a domain. It identifies the triplets as entities, attributes, and values. And if computers can understand each other using ontology, I believe humans can do. That's a pretty optimistic assumption, but it might be the basis for that. So we built all the ICD on that premise, saying that, okay, whether you call it a disease, asthma, or a phenotype, or a gene, can we create all the disease components in an ontological way to put them in a foundation component? Foundation component is, rather than the tabular list of London bills of mortality, is a enmeshed network of disease concepts put into the computers in an ontologically disciplined way. So you may refer to it as the library cartotext, or I also say that all my songs are on my iPhone, okay, but I can, develop different playlists. So the hard disk compilation is the foundation, and the playlists are the linearizations. So I can use one song more than once in different playlists, so we can make linearizations. If mortality people want to have a linearization and they want to use melanoma as a skin tumor, that's fine, okay? But dermatologists would use it as a skin tumor, and I can use it in a second linearization as well. So the multiple views can coexist jointly without excluding each other. And computers do allow that, and ICD-11 as a novel methodology embedded in it does do that as well. So in a sense, in the foundation component, we have the definitions, synonyms, clinical descriptions, diagnostic criteria, causal mechanisms, and functional properties of the ICD categories that people use in healthcare. And we use them in a coded way with SNOMED CT, as you know very well in this. I think I'm the first one who's uttering that word in this audience today. But whether you like it or not, or other types of ontologies, we are not bound to only SNOMED CT. And we can create different linearizations for GPs, for primary care, for National Health Statistics Office, for mortality, or for hospitals, for morbidity, and so on and so forth. You can have as many as you like. So that was the advertisement part for WHO and ICD. But I think what I wanted to underpin is that we are aiming to become the digital Rosetta Stone as ICD. So if you can code all your data into SNOMED and ICD, then sharing of data across the borders of Britain, I think that's already what you could easily do, and you can set the templates for that. And for those of you who don't know SNOMED, I think in 1960s, when the first mainframe computers emerged, pathologists who were bored looking through the microscope to their slides tried to put their records into computers. And they, over the years, created 400,000 words. Nobody noticed that compilation until computers arrived. And then, UK wanted to use it. And they said to the Americans, well, I mean, it was the College of American Pathologists who used to maintain them. Well, this is not a good image. You're a college, you're American, and you're pathological. So, and from a marketing perspective, then they changed that to a network, a global network, overall healthcare type of thing, and it's now called ITSIDU, whether it's better than CAP or not. But, and at least we are having this thing to be maintained globally, and we are collaborating as WHO with ITSIDU. And what we are trying to do is taking a core subset of ICD foundation component and SNOMED CT and see whether we can share concepts. They are fully specified names, definitions, and synonyms, all in a same thing. So it is the digital Rosetta Stone. And we have the same parent-child relationships so that there are similar polyhierarchies. So if you say myocardial infarction is a ischemic heart disease, it will do the same path in ICD and in SNOMED. So there will be similar grouping logics and similar content model parameters. I'm a psychiatrist by training, so if you can all look into depression in your patients by this 9 criteria, either you are using ICD or DSM, whatever your favorite thing is, and you can then code electronic health record with SNOMED with these things. And unfortunately, thoughts of that were not coded in SNOMED, but it doesn't matter. They can add it afterwards. Then you can make a search on that electronic health record data similar to HeRC things. I think Georgina mentioned certain things about that as well. So you can see how many of the patients who had sleep problems had depression, how many sleep depressed patients were treated with antidepressants, and so on and so forth. And you can, of course, then create algorithms like archetypes or clinical model templates and so forth, formally representing the knowledge. These are WHO guidelines, how you can define hypertension at different values. So you can probably build filters that will be universally applicable using HeRC type of things. So I think that enables us to go beyond Google, because with all the search functionality that Google provides, it provides a functionality based on a lexical match. So if you type it alphabetically correctly, you can find those concepts. But once you identify it semantically, as we say, in an information model, then you can search concepts about words. How many patients in Manchester have diabetes mellitus type 2, or whatever disease of your preference is? So even if you don't call it diabetes, you can search it with those things, and you can extract concepts from health records. For example, look into the hemoglobin A1C results, which you're already doing, I believe. And then you can make a statistical index in community collections, calculations of the coverage gap. What are the missed opportunities, as we spoke in the morning about that. And you can compare the collections of Greater Manchester to other places as well. So in a sense, that is what the e-research which I call epidemiology or real-time public health, that currently we are collecting these data or its sub-rubrics, and mainly it is, in most parts of the world, is used for reimbursement or resource management for DRGs and so forth. But you can also use it for clinical information, as you're saying, for HeRC and other studies. And when you aggregate them across populations, you can make public health, epidemiology, and surveillance, as we have seen the examples in the morning. So that is the view, and if we do it in an ontologically sound way, then it will be, transportable. It will be, time-proofed, and it will be language-proofed. So what I'm trying to assert is sharing meaning is sharing the meaning at conceptual level, not at the language level. I mean, you already know the jokes that you're separated by the USA, from the USA by a common language. So a common terminology is fine, but a common ontology is a must in a common structure and a common reporting method. That's the point. If you do that, then you have the interoperability, meaningful sharing of data. As you see in this cartoon, we're all trying the same thing, they say, are talking at the cartoon level, but we really want to make them talk in a computer level. So I guess I made my point that absent that interoperability, we'll end up with an E-Tower of Babel. Maybe there will be an immense structure, but nobody will speak the same language, and we'll understand each other. And you already had this. The king, maybe you can liken it in your poetic interpretation to the czar of IT in this country, the previous one. And, well, more important was the man in the red hat, as a detail from this picture, who was trying to have, Lego bricks of the Tower of Babel. It may be Deepak, or it may be any one of you who are working on this thing. And most importantly, to defeat Picasso in his assertion, we really have to have the Turing for informatics. I visited there yesterday, thanks to Alan Rector. I mean, the artist had depicted Turing with an apple in the hand. And I was wondering whether it is the forbidden fruit, or is it the object that fell on Isaac Newton in the legend, whether it's true or not, or is it the witch's apple, as Turing was saying, replicating Snow White's poison's apple, or is it the fruit of the tree of knowledge? And if you have the tree of knowledge fruit, that will be a very useful product for the world. Thank you. You can export it then.